All right. Well, welcome everyone to another Monday, Mainstream Monday VMR. Today, I have the privilege of discussing with Magnus, who I'm sure if you just tune into VMR, you know his face, his voice, and Magnus is one of the VMR leaders. And so VMR runs smoothly in large part because of everything Magnus does. And so excited to co-discuss with you, Magnus. Thank you for everything you do in CP Solvers. I always I'm so grateful for everything you do behind the scenes and love when I get to hear you discuss. So I'm super excited to co-discuss with you today.
Yeah, thank you so much, Mary. I'm also really excited to be discussing not only with you, but also with your very sweet little baby. So you have a helping hand there, and also very excited to be discussing one of Aaron's cases. I think this must be, I've stopped counting, but it must be case number 10,000 or something.
Yep.
I think it's really incredible. It's really not a competition, but if it was, I'm sure everyone would win by a landslide. So yeah, thank you so much.
That's so true. Aaron, you have presented so many cases. So let's hear from everyone who's making the session happen. Aaron, you want to unmute, say hello, maybe share an update with everyone?
Sure. Hi everyone, I'm Aaron. I'm back again with another case. I just have so many cases and yeah, I just keep presenting them because I learned so much even after seeing the patient myself. Just hearing the discussions by everyone here in CPS just makes all the learning even more fun.
I totally agree. I totally agree. I love like presenting cases because you get to relearn from the cases that you've seen. All right, and we have Shreya who is doing a teaching point. Shreya, thank you so much for doing teaching points. Do you want to unmute and say hello?
Yeah, sure. Hi, everyone. I'm Shreya. I'll be doing teaching points, and I'm really excited for this session.
Awesome. And then we have Krishna who is scribing. Krishna, do you want to unmute and say hello?
Hi everyone, I'll be doing scribing today. I'm really excited to hear Aaron's case and Shreya's teaching points in the amazing discussion.
Awesome. Well, let's jump into it. So Krishna, you can go ahead and share your screen whenever you're ready. And Ivan, you can go ahead and start with the first aliquot.
Sure thing. So first we have a 50-year-old male who's coming in for constipation.
All right.
Right.
Magnus, one word.
Yeah, but a very common word, I think. 50-year-old male with constipation. First of all, I think it's a very common thing that we see very often. So I want to know if it's something new or if it has happened to him a lot beforehand, and also for how long this has been going on, just to get a sense of the severity. Like, is it 1 week or is it more like a chronic type of picture? I think that could really help us frame the problem here. And just like thinking broadly about constipation, think many times we don't really find a reason. It can be due to like something simple as pure or poor water intake or something like that, or immobilization. We also see that quite a lot. But it can also be due to other stuff. For example, medications can cause it, especially opioids. And it can also be a motility issue. So something affecting the nerves or the peristalsis in the gut. And finally, also electrolytes can also cause constipation, so hypercalcemia. So it's actually quite a broad differential, and it's really going to be really interesting to see if there are any associated features here.
Yeah, Magnus, that's phenomenal. I mean, just with one word, I think you're picking up on how broad the causes can be, and I love how broad you were in your differential, electrolytes, medications, and then even focusing on the base rate. You know, if there's just been a kind of low fiber in one's diet or low hydration, can definitely worsen that. So you've done, I mean, nothing to add to kind of the causes of constipation. I'm wondering if we could take a moment to think of some of the complications that people can develop when they have constipation. Have you come across, like in your time in the hospital, any complications that come up when you think of constipation?
Yes, I think I haven't seen a lot of complications. I think most of the cases I've seen have been quite mild, but
Yeah.
I think in general it can get quite severe. So you can get like first of all severe pain, abdominal pain, and if you're really if in terms of like severe complications, I know you can get something like stercoral
Yeah.
colitis, so
Yeah.
actually like an inflammation of the colon due to constipation.
Yeah.
So there are some consequences if it's progresses.
Yeah, absolutely. Those are kind of the main ones I was thinking of. Like you exactly said, the stercoral colitis, I think is a important one you wouldn't want to miss. And exactly as you said, you basically kind of from this stool ball get this pressure in the colon that causes kind of this like local ischemia and can get really horrible inflammation from there. So yeah, great. I think like you, I'm really interested in the time course. And as you said, kind of the electrolytes will shed light into if there's a metabolic component driving this. And then the last thing I want to say, I think whenever I see a chief concern, I want to kind of take a pause and make sure we're not missing if this truly is the problem or if there's a mimic we should be considering. And so I imagine if someone starts off by saying constipation, they're referring to the fact that they haven't had a bowel movement in several days. But I think I'm also wanting to know, like, have they been passing gas? Do we need to be worried about a bowel obstruction before just narrowing in on the problem of constipation? So phenomenal discussion, and we can pass the mic back to Elon to hear more.
All right, wonderful discussion so far. So for the history, 2 days prior, the patient noted constipation that was associated with constant, non-radiating hypogastric pain that was rated at 10 out of 10 in severity that started at rest. This was not associated with any fevers, nausea, vomiting, or diarrhea. So the patient took 1 dose of Dulcolax, which is bisacodyl, and Tylenol with one subsequent bowel movement with a subsequent decrease in hypogastric pain as well. The pain is now 6 out of 10 in severity. In the meantime, he still had his hypogastric pain, which now radiated to the more in the left lower quadrant, which is now associated with dysuria. There was no hematuria or flank pain. He took another dose of the Dulcolax without any relief of pain that he previously had. And since the pain was now persisting, even with another Dulcolax, he went to the emergency department for further evaluation. On review of systems, it was otherwise negative. Um, for the past medical history, he is just hypertensive and diabetic. His current medications are Nebivolol and Zigduo. He has no prior surgeries and no known allergies. Family history is just relevant for hypertension and diabetes on the paternal side. Social history is just occasional alcohol use, no smoking, and no illicit drug use. And I'll just stop there.
Magnus, do you want to go first again and I can go after you?
Yeah, for sure. Yeah, so we learn here from this aliquot that he definitely has some abdominal pain, which we also expected. And it seems it has been going on for only 2 days. So it's quite acute, I would say. And he has some he doesn't really have a large effect from the Dulcolax. So I'd also be wondering whether we are just dealing with severe constipation that's like needs more aggressive treatment, or whether there is some underlying problem, for example, something obstructing the bowel that we need to worry about, as you said. But I think it's reassuring that he doesn't have any like red flags in terms of also severe vomiting or high fever or any like long-standing chronic history of weight loss. I think those issues would definitely make me worry for a more sinister course. But I think still really figuring out whether there's something serious going on in the acute setting is important. What do you think? What do you think, Maddie?
Yeah, absolutely. I think the to add to the points you made, I think the other thing that stood out to me is the dysuria that he reported. And I'd be curious if that was kind of a similar time course with the constipation or something different, because when we were thinking of some of the complications of constipation, one kind of complication to add to that is you can get fistulas. And so I think with the dysuria popped the hypothesis into my mind of could there be a colovesicular fistula that developed from the constipation. I'd be surprised that if I'm wondering if that would be the case, a fistula would develop when you've had more than 2 days of constipation. But you always have to be kind of, I guess, cautious with time course because sometimes patients, let's see, the duration of symptoms that the patient notices can sometimes be different than the duration of symptoms kind of basically patients can have like symptoms that they don't notice and then notice the symptoms it comes to their detection later on. But so the dysuria just popped the hypothesis of fistula in my mind as a complication of constipation. And then I just wanted to highlight, I believe Sam and Lyra brought this up in the chat, like the fact that he has a history of diabetes, you can get, we know that there's all different types of neuropathy that you can get from, high blood glucose levels, and you can get autonomic neuropathy, which can kind of lead to constipation. So that would just prompt me to kind of look at the A1C and ask a little bit about how well controlled that's been. That's everything I wanted to add here. I'm curious if Magnus, like if you were admitting this person or just kind of seeing them, what you think you would do as part of the next steps in their workup.
Yeah, so I think definitely a good exam is gonna be important. Just look at the vital signs, just to be sure that he is stable.
Mm-hmm.
And also a rectal exam is gonna be important. I think just to get a sense if there's could be some tumor or some apparent thing that we're not thinking about right now.
Yeah.
Doing that as well is key here. Then I think some basic labs to see whether there's any like inflammation going on. Dysuria could be, as you said, from a fistula, but it could also be like a separate etiology. Could you have a urinary tract infection? Could you have some irritation from the constipation that's also leading to dysuria? Or
Yeah.
could it be that he has urinary retention as well, and
Mm-hmm.
then has some if it has been going on for some time, that's also a risk factor for a UTI. So yeah, so there are
Yeah.
a lot of possibilities here, I think.
Yeah. And actually, Magnus, as you were speaking, you kind of made me think of an analogy in the way we can think of constipation. So um, for dysphagia or like difficulty swallowing, the CPSR has a great schema that kind of breaks it down into is it a structural issue or a motility issue? And I think constipation, we can think of it in the same way. It's basically like dysphagia, but just on the other end of the GI system. You just like, can't get stool out. And so I think we can almost think of it in a similar way. Like, is there a structural issue? Like, as you said, is there a cancer, like a mass in the colon that's preventing stool from coming out? Or is it a motility issue, which would trace back to some of the like metabolic hypotheses you have, like hypercalcemia? So I think to your point, kind of thinking of it in those two categories might be a helpful way to frame the problem as we keep going. All right, Iran, back to you.
All right. So for the physical exam, the vitals, temperature is 37 Celsius. Heart rate was 85. Blood pressure was 110/70. The respiratory rate was 20. He was satting 100% on room air, and BMI was 25. For the exam, it was otherwise unremarkable for the heart and lungs. For the abdominal exam, the abdomen was non-distended. There were no surgical scars. Bowel sounds were normal. Uh, the abdomen was soft with tenderness in the bilateral lower quadrants, with some rebound in the bilateral lower quadrants. There was no guarding. Rectal exam was unremarkable. No tenderness in the prostate, no masses, no gross blood. The rest of the exam was unremarkable. I can stop here or I can give you guys the basic labs.
Iran, totally up to you. I know, given that we have like 12 minutes left, whatever you think timing wise in terms of how much case you have.
Sure. I just have the basic labs and then imaging would be like the last aliquot.
Okay. You want to give us maybe the basic labs and then we can
Sure.
discuss
Yeah,
after that?
sure. Yeah, so for the basic labs, I'll start with the CBC. The WBC count was 12,000. The hemoglobin was 15.2. Platelets were 347 and with an MCP of 80. For the chemistries, the sodium was 140, the potassium was 4.4, chloride was 99, bicarb, I don't have. Creatinine was zero point 0.8, the BUN was 10. We had a glucose of 111, ionized calcium of 1.1. Um, and then UA was notable for 4 plus glucose and 2 plus ketones. No RBCs, WBCs on microscopy. He also had an A1C of 6.8, and they did a lipid profile that was otherwise normal. They also did an EKG and chest X-ray, which were also unremarkable. And I'll stop there.
Thank you so much, Aaron. I think what really stood out to me from this Alcott was the rebound tenderness, I think, in the lower abdomen, which I really think can be a sign of like peritoneal inflammation. So we might be dealing with something a little unusual for like a standard normal constipation, I think. And when we move to the labs, we also receive that he has like a little elevated white count, but I think apart from that, I don't see any like severe um, elevations or alterations, except his creatinine was. I'm not sure I got his baseline if that was elevated. But apart from that, I think he has diabetes. He has some glucose in his urine, some ketones. Still, we also want to like when we see a patient with abdominal pain, we want to get a blood glucose as well, just to make sure they're not in ketoacidosis. Like he has type 2 diabetes, so that would be less common, but still making sure that the glucose is not like severely elevated. But I think that's my key takeaways from this aliquot, and I'm thinking that the next step might be a CT scan of the abdomen to reveal whether there's any structural things we could see on the CT. Yeah, but I'm very curious how you are thinking about the problem so far, Maddie.
I'm I'm right there with you, Magnus. I think exactly as you said, what stood out to me in the physical exam, what was most concerning was that rebound tenderness. And the way I think of it, you described it very well. It's like when you press on the patient's abdomen and then release, there's more pain with kind of the release of the pressure. And that, exactly as you said, makes should make you concerned for kind of peritoneal irritation or something like peritonitis. And so I think you're right. And someone with constipation and dysuria, and kind of going back to the complications of constipation, could there have been some type of perforation that has caused peritonitis? And so I absolutely agree with you that I would want to get a CT scan in this patient to kind of rule out that possibility, especially with the mild leukocytosis as well. The other thing to add here, Nima in the chat mentioned a euglycemic DKA, and I think that's a really, really great hypothesis here. You know, we have she's euglycemic, she has diabetes, and she has, I guess we don't know the bicarb, so I guess we don't know if she has an acidosis, but I think that's I think that's a really great hypothesis. I think that what that would prompt me to do is probably to get a blood gas to see if there is acidosis at play. And then you can get a beta hydroxybutyrate to assess, kind of like to further assess for ketones in the serum. So I'd probably start there, but I think either way, I would probably be wanting to get a CT scan to make sure with that rebound tenderness and the severe pain that they're having from the constipation. Um, Anything else? So I guess, I don't, anything else that you wanted to add, Magnus? It sounds like Elon gave us a clue that we have imaging next. Like let's hypothesize. What do we think it will show? And please, people in the chat, put your hypotheses down. What do you think the imaging will show? And what type of imaging do you think Elon got?
Yeah, so I think looking for a perforation, as you said, would be would it could be very interesting to see. I think it's also like it's in both the right and the left lower quadrant, so it might be a
Mm-hmm.
little bit more diffuse than, let's say, a simple appendicitis or diverticulitis, although it can be very hard to or we cannot diagnose that on exam because it can present in so many different ways and so many different pain syndromes.
Yeah.
But I think an obstruction or like a perforation would be interesting. And I also really like the thought about euglycemic DKA, keeping in mind that I think he's on an SGLT2 inhibitor. So getting ketones, as you say, is also a really rapid test just to rule that out. Yeah.
Yeah. Yeah, I'm right there with you. I think I'm concerned for a perforation as well. And I think kind of going back to our um, constipation, there being, is there a structural or a motility issue? I'm trying to think, is there a possibility this person has a mass or, a cancer for some reason that's caused the constipation? But I think the fact that there has not been weight loss, night sweats, other systemic signs perhaps makes that a little bit less likely. So I'm curious what the imaging shows, but like you, I'm worried about a perforation in this person. Yeah. Um, all right, Iran, back to you.
All right. So for the imaging done in the emergency department, they did a CT abdomen pelvis non-con, which showed colonic diverticulosis, wall thickening, as well as moderate stranding densities in the mid-sigmoid colon, consistent with diverticulitis. They also found a 1.7 cm focus of fluid and air collection seen intimately related to the undersurface of the sigmoid and left superior wall of the urinary bladder. There's also partially filled urinary bladder with wall thickening, which may relate to underlying cystitis. Otherwise, gas pattern was non-obstructive, no mass lesions in the intestines. Appendix is intact and a fluid-filled small bowel. But otherwise, the impression they called it colonic diverticulosis with diverticulitis with probable abscess formation. And they actually called a question mark bladder bowel fistula. So they did the CT with added contrast, and that one it showed the same thing, diffuse wall thickening, but a lesser degree. And the proximal segment of the sigmoid colon remained intimately related to the posterior wall of the urinary bladder without definite fistulous tract or contrast extravasation. So the end diagnosis was just acute sigmoid diverticulitis, Hinchey 1A.
Wow, fantastic case, Iran. Magnus, what do you think? Any reflections on this?
Yeah, fantastic case and amazing presentation as always. Iran is yeah, it's such a treat. I think for me it's just an emphasis of like how tough abdominal pain can be to diagnose without imaging. Like it can have so many presentations and so many different features that it's a really broad differential, and even with imaging, sometimes we struggle. So yeah, I think that's just my key takeaway from this. And then diverticulitis is such a common condition, but again, seeing it here with these associated symptoms. It's not something that I think of when I hear constipation, for example, usually. So I think that's really nice. Thank you so much.
Yeah, Magnus, I thought your discussion was phenomenal. And I totally agree with you about how challenging abdominal pain can be to diagnose kind of without imaging often. But I think one thing I want to share, I'm going to paste this in the chat, is there's a schema on diverticulitis complications on the website. And I think this case really highlights this very well. And we're seeing basically kind of the basically an acute on chronic, I'm thinking of it, kind of complication of constipation. So you get diverticulosis in large part from constipation, and then you can get kind of inflammation and infection of those diverticula that I think might be causing this acute presentation. And then you can see in the schema, but some of the complications can be perforation that can lead to an abscess. From this inflammation, you can get obstruction that can kind of worsen constipation. It can get fistulization. So I think this case is like a perfect example of a lot of the complications you have to be aware of with diverticulitis. Ewan, did you want to share any kind of takeaways or reflections you had from this case?
Yeah, no, exactly what you said. Just the complications of diverticulitis. The interesting part was the imaging with the dysuria when the dysuria came in. So there was initially concern for the vesicular fistula there. So we had more imaging, which effectively ruled it out. But yeah, just learning about and seeing a possible complication of diverticulitis was the highlight of this case for me,
Yeah,
aside from the presentation of constipation.
absolutely. Well, thank you so much, Aaron, for bringing another fantastic bread and butter case to these Monday sessions. Magnus, your discussion was so incredible. I love discussing with you. And Shreya, we'll pass the mic to you for teaching points.
Sure. What a great case, Aaron. Thank you for bringing this, and what a fantastic discussion, you two. So we had a patient of 50-year-old male coming to us with a complaint of constipation. So with constipation, we were thinking of all sorts of things like, is it new or is it something chronic? Is it a structural issue like a mass or cancer, or is it a metabolic issue with something going wrong with electrolytes in the body? What is the severity of the constipation? And what could be the reason behind it? Is it a medication that patient is using? Is it, again, an electrolyte abnormality, or is it the diet of the patient that is affecting his peristalsis, or is it activity-based? And we also need to rule out what is the baseline stool of the patient. Is there any soft stool episode in between? And what can be the complication should always be kept in mind, like fissure, an infection, or inflammation, any obstruction, or any fistula. So we need to figure out whether it's severe constipation as a separate entity, or is something underlying anything else going on. And the patient had lower abdominal pain with rebound tenderness in both quadrant. So when we have rebound tenderness in abdomen, we need to rule out. We need to always think of peritoneal inflammation. So we need CT to rule out this. And we had another complaint of dysuria in patients. So whenever patient has constipation with dysuria, we should always think any connection involving both organs and affecting them, like colovesical fistula. So the patient's glucose being normal, but with patient coming with glucosuria and ketonuria, and patient has a history of using SGLT2 inhibitor. So we were also thinking of possibility of euglycemic decay. So the diagnosis came back to be diverticulitis when patient. So the pathophysiology basically is the patient having constipation can lead to diverticulosis, and then it can lead to infection, diverticulitis, and that can lead to complications like perforation or abscess. It was an absolute really wonderful case. Thank you all for this lovely discussion.
Absolutely amazing teaching point, Shreya. Thank you so much for summarizing the teaching so well. Shout out to Krishna for scribing. And thank you all for tuning in today. All right, we'll see you all next time.